Tracy, I sent you the link.
I got it. Oh, hold on. Good to go, guys. Can you hear me?
Yes, I'm letting everyone know.
So Tracy, is the link up on the website?
Yes, sir, it is.
All right, Ms. Darby, you are ready to roll.
Okay, do we need to wait for more people? I'm gonna feel like everybody's not here.
Right, and okay, there, finally, I was struggling to get myself unmuted. Yeah, I don't know that we have,
1, 2, 3, 4, 5. There's only 5 of us right now.
Okay.
oh, where is everybody?
Well, we know, so we're waiting on Raylena and Glenn, right?
Yeah, and there were only 2 that said they couldn't make it. I wonder if they're having trouble getting on. Has anyone texted you?
No, I'm texting them right now. Oh
Okay,
yeah, Raylena needs the,
she needs the
Raylena
link.
says she needs the link. Mine disappeared this morning too. It was bizarre.
Okay.
Raylena.crooks.va.
Jacinta, Olivia, could you mail or resend that invitation with the link for Raylena?
I will resend it to everyone. They do have
Thank
a
you.
form. They can start.
You do have a quorum if you want to start. You can
Well,
wait.
no, we only have 4 members. No, wait, yeah, we have 5. We do have 5. I forgot about myself.
Okay, yeah, we have 5. Okay, let's go ahead and get it rolling and I'm sure she'll pop in.
Yeah.
Okay,
So let me start the screen share. And there you are.
okay, thank you. A meeting of the Louisiana State Board of Medical Examiners Occupational Therapy Advisory Committee pursuant to lawful notice is duly convened and called to order at 10:03 Friday, April 14th, 2023 via Zoom virtual video. Please note any comments by the public are welcome and can be emailed to publiccomment@lsbme.la.gov. Dr. Van, please confirm that you have verified the identity of all tele and video conference participants.
At this time, we have confirmed all the identities.
Thank you. Is the sound clear and audible to the public and those on the tele and video conference?
I'm assured it is, ma'am.
Thank you. All additions to the executive or public agenda must be made presently, as we will no longer make additions to the agenda after the close of the public session.
And we do need to have a motion to add that letter that we discussed, we sent to you yesterday, since it didn't make the agenda. Well, I think, so I want to make sure.
Okay, the agenda that I had, it was on there, but
It's on there, Dr. Van. You might, I guess you don't have the
I got
updated
the
one, but
wrong
it is on
agenda.
there.
I apologize. Let me go get the right
that's
agenda.
okay.
It changed so fast, I missed it. I apologize.
Olivia's good. She's quick.
Okay, OT minutes. Where's the agenda, OT? Is that the same thing as the minutes document you sent me?
Dr. Van, I already sent it to you, but give me a second. I got you right now. It's that one.
Okay. It's the
Okay.
minutes, new business. Okay, let's see. All right, I guess this is one.
I'm going to go ahead and review the mission if that's okay.
Yeah, please.
Yep, the mission of the OT Advisory Committee is ultimately to protect the public, that is the consumers of occupational therapy, by regulating competent practice and upholding the standards set forth by the governing rules and regulations. I'm just going to make sure that we have everyone here. We have Carolyn Murphy, Brenda Martin, Ingrid Frank, Tracy Morrow from IT, Patricia Wilton, Kelly Brandon, Dr. Vincent Collada.
Here.
Jacinta and Olivia. They're both here.
Yes, and Glenn just got on. I don't know if you called his name out, but he should be on now.
I'm
Yep,
here.
I see it
Sorry
now.
for
Hi,
sorry for
Glenn.
being a few minutes late. Hey guys.
No, welcome. No worries. Welcome. And Raylena should be in any minute too. Thanks for letting me know. Okay.
You're welcome. Yeah.
And Glenn's there. Yep. All right. Great.
All right, so now I got the right minutes.
Ingrid, can you just confirm, please, that we do have a quorum?
Yes, we do have a quorum.
Okay, thank you. All right, if everyone can turn their attention to the minutes from the March 10th meeting that was provided on the link. If there are no changes or amendments, if someone could please make a motion to accept the minutes as written.
This is Brenda. I move to accept the minutes.
Thank you, Brenda.
Kelly, I'll second.
Kelly seconds it. Thank you. All in favor, please say aye.
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 Anyone opposed? And anyone abstain? Okay, and Dr. Van, can you please check if there's any public comments related to the minute?
No, ma'am. And just to remind everybody who's watching, if you want to make comments, you can address them by email to publiccomment@lsbme.la.gov.
Okay. Thank you. Merci. Hey, Raylena, were you able to pop in?
Yeah, I'm
Okay.
here. I'm doing it on my phone though, so this is all new to me. I'm trying to like maneuver where my mute, but oh, there it is. So just be patient with me, I guess.
Well, that's
Glad
fine.
to
Thank
have
you. Okay. Okay, so the first thing on the agenda under old business after the approval of the minutes is the LOTA update. So I attended the LOTA conference and sat on a panel with Sean Conway, who is with NBCOT, and Chuck Wilmar from AOTA about the OT Compact. It was basically just an information session for the participants. General questions were asked about home licensing state that were clarified. Pretty basic questions, practices such as like dry needling. And we just emphasized the importance that the practitioners have to be familiar with their home states and each other state that they are licensed in with their rules and regulations. So it's pretty uneventful. Like I said, it was just event sharing and nothing further on that. Then I gave an update on behalf of OTAC at the business luncheon, just mentioned that we were updating the rules and regulations. I also mentioned to him about the email that would be sent out regarding the laws and rules course. I announced that there were 2 OTAC member spots that would be open for 2024. And those that information will come out in June, which is just in a few months, and just explained a little bit about what the roles are and the purpose to try to recruit some people, especially OT assistants that were in participation. And Dr. Van and Jacinta Olivia just let us know at some point what we need to do to prepare for that, just so we can get that notice out in a timely fashion. Then the other update from LOTA is that the OT Compact bill, as we know, is submitted. They are looking for OTs to discuss this and to be present for discussion with the Senate on Tuesday, April 14th. They're hoping to discuss the telehealth bill with the House on Monday, April 24th, which is also their Hill Day, is what they call it, where the OTs go to the Capitol and advocate for the profession. Jennifer Lucky, the president, also let me know that OTs were named specifically in a few bills that originally stated other healthcare providers, but they're amended it so that we would specifically be named as OT practitioners, and that would, she gave me some examples, like there's a council on wholeness and community reintegration that she felt like was, you know, right up our alley. So that was one of them that they wanted to be named. And then also as a healthcare provider that would be participating in the documentation of a child, a person with autism that would be required for an autism license plate. So those were just some of the examples that she gave where, for example, in the autism one, it said a physician and a speech therapist. And so they were just trying to also include occupational therapy. So that's basically it for the LOTA update in the spring conference. So
Darby, did you say that the telehealth bill was coming up on the 14th and the compact on the 24th?
you have on the opposite. The compact
Opposite.
is the 18th. Yeah, and I'll send you my notes. And the telehealth bill is on the 24th. And that's just where they have OTs present who can discuss it with members of the Senate or the House who have questions. And AOTA provides them with a lot of like information of bullet points to say and things and support. So they don't suspect that we'll have any trouble with the compact, but they just like people being there in case there are questions.
Darby, if I may take an opportunity to advise you, be very cautious, know a little bit about the fees, because our doctors are finding that it costs about 3.5 to 4 times as much to get an compact license as to get just an unrestricted license in Louisiana. Additionally, some people have had issues in their past that precludes getting a compact license. We've had very fine physicians who had trouble in their residencies for various and sundry reasons. They can't get compact licenses. So understand that if they follow the pattern of the MDs and you all don't make sure that those compact rules that are going to be written into stone in our legislature, make sure that you understand that there may be some unintended consequences, so that you have to not just assume that it's going to be beautiful and the roses are going to shine. There may be a few dead roses in there you want to know about before you buy that bundle.
Okay. And when you say that, I mean, that's really more something for LOTA to review.
Well, if you're giving testimony and you say it's a good idea, I don't want people to come back at you and say, well, you didn't tell us it would be more expensive.
Yeah,
Or you
no,
didn't
I'm not
tell us I
giving
can't get
testimony.
one. Yeah, okay. I'm just
I'm
saying
not
anybody,
giving testimony.
but
They're
understand.
looking for OTs to do it, but
Yeah.
I am not, I did not volunteer.
Okay, well, I'm just saying to y'all,
Yeah,
just sometimes it ends up being buying a pig in a poke.
no,
Yeah,
I
just-
appreciate the advice and I will pass it on to Jennifer. I was just announcing the dates that they're looking for people, but I did not commit to
Yeah.
do that. Okay, good, thank you for that, because I know Jennifer's she goes early to the conference to meet, and that is something, you know, on her agenda, so I'll pass that information. That's extremely helpful. Okay, any other questions about the LOTA update? Comments? Do we have any public comment?
I do have a question.
Yeah.
Okay, so if we enter into the compact, do you have an option to get just a Louisiana license, or will
Yes,
it
ma'am.
be?
You will
Okay.
still be able to just simply have a Louisiana license.
Okay,
It's when you decide, oh, I want to get a Mississippi and an Alabama license because they have joined the compact. Now, in the beginning, it usually takes 10 or more states. So you don't know how many states initially sign up. So we'll get the law passed and you won't even be operational if we're some of the first people to do it. But then the problem is that what's happened to physicians is, well, it looks like a good deal. I'll get one to get a Mississippi license. And then they find out it would have been easier to just go directly to Mississippi and get the license. I mean, it's everybody's choice, but it is easier, but more expensive. So I think that's the trade-off you make.
And Caroline, when you asked that question, did you mean like you can still get a Louisiana one. Does that mean like if that's your home state or if you don't live in Louisiana?
Like if I plan on just practicing in Louisiana and I don't want to enter, get a license that would be, applicable for the compact, can I just get that?
Yes,
So,
ma'am.
yeah.
The vast majority of physicians in Louisiana do not have a compact license.
Okay.
And with the compact, that our procedure to get one in this home state would not change. Is that correct?
To get what and what? I'm sorry, I
A
want to make sure.
license in our state. So like if a new grad OT and we're part of the compact, say in a year, then our procedure to get one just in Louisiana would be.
If you just want to be licensed in Louisiana, a normal unrestricted license to practice OT, will be unchanged from what you see today.
Gotcha.
It's when you move into, I want to get a compact license.
Gotcha. Okay. Thank you for that clarification. Great question, Carolyn. Okay. Do we have any public comment?
None yet, ma'am.
Okay, let's move on. The next item is the laws and rules email. So hopefully everyone here got the email blast that was sent out on Tuesday, April 4th. That just stated that as the LSBME wanted to let all OTs and OTAs know that a new course is available in CE Broker. The course is titled Occupational Therapy Laws and Rules, and it was free to complete on CE Broker. So did everyone on the committee get that email? Okay. So good. So that's really just letting you know, like, we can check that box. Ingrid, you've been the one working mostly on that. And
Yay.
Susie, I don't think is here, but that's been a long time coming, years and years. That was probably one of the things that when Brenda and I first started, that was being mentioned and we started making the questions. So yeah, we appreciate everybody, like especially Susie, who I don't think is on here today, but she's been amazing. And Ingrid had a huge role in that of starting with the questions. So another thing done. Anyone have any questions or comments on that? Was
I
some of
have
y'all able to
something.
actually take the test?
Yeah, I took it. And I had two things that I had sent to Susie because she said she was the only one who could receive feedback for it.
Yeah.
So I'm gonna stick with following that rule of saying that, like, I gave her my feedback, but
Okay.
is this the place is this the place and time to be able to discuss if we have feedback for that? Are we gonna talk about that together at some point? Or no, it just has to be sent to Susie and then she's gonna deal with that.
I think you can bring it up now. I mean,
Yeah.
I'd like to know, yeah.
Yeah.
Okay, because it was said that, like, we couldn't discuss it among, like, in the email it said we couldn't discuss our feedback with other people, just with
Oh,
her.
well, what she doesn't want is for the questions to get out to the public.
Oh, okay. Well, I mean, I have no plans of doing that.
Right.
And we're in a public meeting right now, so I guess it's sort of, if your feedback doesn't include like verbatim talking about what the question exactly.
Yeah, it's specifically related to two questions.
Okay.
So then if that's the case, we can do that at a different time. I'm not trying to say to create another room where we go and be private like we've done in the past since other meetings. But I've sent my feedback to her.
Okay.
I think I'm mostly satisfied with all of it except for like two questions. So other than that, I think it looked great. I like the user. I can say this, that I can tell that a lot of work went into it. And I really like the UI of it. I think it's good. It's intuitive and easy to use. And I like how the pretest, like in the pretest, it pops up like with feedback in green to explain it.
Mhm.
I liked that. So I thought all of that was good. And then specifically related to those two questions, I can just trust Susie that she'll do with my feedback.
Well, no, it's good.
Whatever.
I'll email Susie and find out from her, and then and she
Okay.
and I collaborate on that again.
Okay, cool.
Yeah, and Glenn, thank you for that, but it
Yeah.
does bring up a point that if anyone on the committee gets feedback from that, like the avenue would be to just forward it to Susie. You can include Ingrid and I on it, but just forward it to Susie because, I mean, it's gonna be like a loop. Susie will get back to Ingrid and me, and we'll kind of hash it out and do it. I mean, I think it's, from me personally taking it, I can see that a lot of people are going to like question and have some aha moments, because I've heard that feedback already. One particularly being about the reval that we discussed. And you know, it's going to happen, but again, the whole point of it is so that people are familiar with the rules. People are also like saying, well, I thought we were going to change that. And I'm like, but it's not changed. So we have to go with how it's written now. And so I
Right.
think it is going to bring up a lot of things where people, especially with the supervision, that's what I've gotten most of the comments about, of like, oh my gosh, like this is making it impossible. And I'm like, we are in the works of trying to change it, but this is the rules as of now. And that's what we have to follow.
I can speak generally to two of the things. I think one thing there's made mention of information like feedback that will be provided later in one of the questions, and I think that it should be provided sooner, like in the green thing that pops up to tell you information about like why the correct answer is what it is. I think in one of those questions, I think that should be provided there as well as later. So that was my feedback for that specific question. I think that was number 7 on the exam. And then another one was related to the reevaluation process and when you're supposed to do what, based on what I could find in the rules and regs, and then based on how the question is worded and how the answers are worded. I wasn't satisfied. Like, I feel like there's a way to like test somebody's knowledge, but without the way that it's currently worded. So she has my feedback on that. And so I think that's not giving away anything.
No, Glenn, and let me tell you, I appreciate that you took the time to give the feedback. I really do. Takes a lot of eyes to make a good test. So
it's the only way that we're gonna like hash through everything. Like, trust me, when Ingrid and I took it, I think we both had like 2 pages.
Yeah. So it was, I only took issue with number 7 and number 9. So, but everything
those 2 are random. So nobody will ever get number 7 and number 9 the same as you. So just so you know.
Okay. Oh, well, random, okay. Well then, okay, sure.
She may be able to tell on your test which was which, but she knows pretty much every question.
Okay.
Like Ingrid and I, we got to a point where we could just like name the people and we knew what question that we were talking about. So thank you so much for the feedback. And please, like, we want to make it so that it's user-friendly, but also like informative. And, you know, if something's too ambiguous, we need to clean it up. Like, so
I really didn't see any issues there. I think it's definitely user-friendly. I think, and then I think you guys also did a good job of like breaking up all of the information. Like, you take the practice test and then you get a refresher that's like easier to digest after that, and then you take the real thing. And I think that like all of the way that you go through all of that is also, it's a lot, but you guys did a good job of breaking it up in a good way that is easy to, that like doesn't make it just overwhelming, and kind of helps highlight the, you know, makes it easy to read and highlights all the necessary information. So all of the rest of that looks good. It was just, I tried to take it with the same kind of attitude that I think people are going to take and be like, well, I feel like it's this. You know, there's going to be a lot of feelings that go into taking this test rather than taking this test based on what the information says. And so, because I think when people come back and give us feedback, it's going to be, they're going to want to just like feel justified in their answers based on how they feel about how they should have done. And so that's kind of trying to play devil's advocate through taking the test. So that's kind of where I came up with those 2 things.
Thank
Yeah,
you.
well, thank you.
Yeah.
Okay, Dr. Van, do we have any public comment regarding that email or agenda
None at
item?
this time.
Okay, thank
This,
you.
this is the email, and you sent me some information. I'm ready to throw all the stuff you sent up on the screen whenever you get to it.
Okay, yeah, so we're gonna, like historically we do, we're gonna table the rules and regs review and update for a minute. Then we're gonna tackle the new business item of the email that Dr. Van got and then come back to the rules and regs. So Dr. Van,
Can y'all see it? Can y'all read it? Do I need to make it
Yeah.
bigger?
It's very small on my
All right,
screen.
let's see what I can do to make it bigger. Give me a second.
I included this in my notes.
If you, I don't know if this is the issue for anybody, but if you hover towards the top of your screen under view options,
Here it
you
is.
can click 100%.
I got it right here. So I just have to make sure I show it to y'all. Center it up. Is it readable now?
Bring it back down, Dr. Van, it went up too high. There we go, perfect.
Okay,
Yep.
y'all can read that? Everybody can read that?
Yeah,
If
You want
you're, just as an FYI, if your Zoom it has the entire thing very narrow, if you go to the top of your view options on Zoom and click 100%, it'll expand your screen. So I just had that issue.
okay, so basically this is an occupational therapist, an OT assistant that's working in pediatrics. And she is talking about basically the practicing mental health for children, and specifically with exposure response or ERP prevention therapy, which helps with like anxiety, and OCD is what she names. So I took it to mean that she's considering getting certified to help. And she mentions children's, adolescents, adults, and getting training in this treatment modality. So it would be basically to help those with OCD or obsessive compulsive disorder. So she's asking, is it possible that she could receive the training and be certified to use it in her practice? And so, you know, I went on being in pediatrics, like we do have some children with OCD trauma response. And I know that AOTA has put out a few publications, especially like in OT practice, about trauma. A lot of it was related to COVID, but some of it's not, and just trauma in kids in general and those in the school system. And I mean, I felt like this really isn't out of the scope of practice. I provided Dr. Van, I think I sent it to y'all as well, just some information that AOTA had on OCD specifically. Then I went to the PESI website and found, I don't know if this is the one that she is talking about specifically, but basically there is a course that I found. I didn't keep digging just because it was becoming like it was just getting too much about. It mentioned specifically this exposure and response prevention for OCD. You know, Dr. Van, when you commented to extend practice, I think I was a little confused because I feel like this is within the realm of practice, and I felt like the question would really be to LOTA to see if it would be approved by them. But
I have just something to say about it real quick.
Okay.
If you scroll to the bottom of that email, the bottom of that, Darby.
Mm-hmm.
The bottom of the email, or?
No, the bottom of this document right here for the course.
Okay.
Like I screenshotted something from the bottom of that as a reference to come back to that. But a lot of the language that's used, that the course objectives, that's what it is. It's at the bottom. Is
Wait, stop.
You passed the course objectives. Yeah, go back up. There they are.
Right there, yeah. The language that's used right there, so number one, the thing that I saw the most is this is really for licensed counselors and therapists. Not that we can't incorporate other things. You know, I work in mental health right now, but that's the main population that's going there. So number one, there's that. Number two, through the objectives, not that she can't go through this course and learn these things, but the application of this treatment method, I guess from me not being number one outpatient and number two pediatric, I'm going to have to lean on you guys who do that specifically, and then maybe Kelly because she's more experienced with OTAs. But my concern would be once you gain this expertise, like, do you then, I think you kind of walk a tightrope of like, are you doing the work of an OT and not the OTA? Because this is highly specific and assessment is used many times in the objectives, like learn how to assess and do these things. Not that, I mean, we can debate with the definition of assessment and what that means, but I think you would be, there would be the temptation to act as if an OT, and as long as she's able to maintain her role as the OTA while gaining this knowledge, I would say that's within our scope of practice and that would be fine. But the fact that she's an OTA asking, can I use and do this? My only concern would be that she sticks within the realm of like what she's professionally licensed to do with this new knowledge. So that's really my specific feedback on this in all of that.
And
Well, I
Darby,
think
what I'm showing you on the screen, Darby, just so you'll know, this is from the website that does the education, and this is what he was alluding to. This is who this course is addressed to. And nowhere does it say OT or OTA.
Right, but I'm not, was that sent from the person who emailed you?
You emailed me this.
Right, right. So this is an example. This is not necessarily the course that she would be taking.
Well,
I
and
just
again,
pulled up to see
okay.
what would be, you know, that course was just an example that I sent to
Okay.
Kelsey. I feel like this is two issues, and Brenda, I see that you have your hand raised. One is a continuing education DEU approval. That's not our job anymore. So that would be up to LOTA. The other thing is a supervision being an assistant. So
I guess what I want, you know, because I have no problem with what you recommend bringing it to the board, but I think we need to be clear. Things like CBT, is that part of and standard of care for OTs?
Cognitive behavioral therapy, yes.
Yes.
Definitely.
Okay. And that's done without consultation with a physician?
Yes.
I mean, you would get the patient would be referred to you by a physician.
But for example, though, and this is why if we approve this, one of the things we got to put in the rule is, and I got no problem, I'm trying to tell you, the rule states that you can treat without a consultation if it's in an educational setting. So my concern is we'll be having OTs doing CBT, and there may be an allegation that they are actually functioning as licensed clinical therapists or psychologists when they don't have the training to do so. So we got to make sure if you're going to change that, to add that, we may have to say in the school-based setting, we need to have a consultation with a licensed therapist, psychologist, or psychiatrist that recommends CBT. I'm not saying, you know, there's a hook there that you got to be careful.
So CBT is more so a methodology. It's not necessarily a certification that you go. It's not like certified hand therapist. It's not that kind of designation. At least that's my understanding of it. So
the course that we talked about is that these people will be certified to do this. Now, again, we don't know what course she has. So
CDT. I'm sorry. I thought you said CBT. I'm sorry.
Okay. All right. But again, is right now, for example, are you all in core training in the schools? Are you taught modalities to treat OCD and that kind of stuff right now?
We do have an entire semester course is called Occupational Therapy with Mental Health. And yeah, all of those diagnoses are covered, and including cognitive behavioral therapy is covered as a modality.
Okay,
I personally have never heard of ERP. Just from what I've seen, I would say that would be within the scope of OT. I agree with Glenn's, this particular OTA just would need to make sure that they're not attempting to do assessment, but that would be true of almost any course that an OTA attends. The loads of courses that an OTA attends would include an assessment or evaluation component that for them is not going to be relevant.
all right, I want you to understand, we're going to put together, I'm going to give you these cautions, and we're going to put this together in two things. Number one, as Darby said, first of all, we don't get in the business of the course and we can respond saying this is something for LOTA or AOTA to approve, not us. The rest of this is we're going to be changing the rules to accommodate it. I want to make sure that we are clear, because when we call this to the attention of the board, I have 2 psychiatrists on the board, and I don't want them to be concerned about the proper treatment without adequate diagnosis and physician or clinical psychologist or medical prescribing psychologist involved. So again, that's the only thing I want to caution you about. We're going to put it any way you want it in the rules, and it's going to go to the board, and they're going to deal with it after we get finished with it. So
But Dr. Van, why does this particular modality have to be specified? Is there, unlike dry needling, or other invasive modalities which have the potential to harm a patient, does this ERP have the potential to harm a patient?
I guess, and I want to be very candid. You answered some questions to me that I did not even know about, okay? And so when the board looks at this and realizes that you all are actually doing this right now, okay, they may have a change of heart. But what I'm saying to you is, when you're treating and you're giving therapy for, psychiatric mental illness problems, and you're doing it without an MD or a clinical psychologist involved, I think the board may have some pause. Now, I could be completely wrong. I just want to tell you that it's a very conservative bunch. And I just don't want to call this to their attention and have them scrap our whole rule effort if we don't address it in the get-go. And right now, remember that in the educational environment, I don't think anybody realized y'all were doing mental health therapy. So we're going to call it to their attention, and then they're going to have some comments.
Brenda, do you want to?
So we're not necessarily only providing mental health services in the educational environment. I mean, OTs do practice that as a part of the core curriculum or core basis across the board. And I guess my concern when I was looking at the concept, number one, wondering what is the question? Is it, are we going to approve the CEU? Is it, are we going to say OTs can do ERP? Or was she asking, can we go to bat and say that OTs can be someone who can even get this certification? Because right now, from the certification courses I saw, OTs aren't listed as a person who it could be applied to. Even the PESI course lists who is approved for their continuing ed, and it doesn't list OT, whereas in a lot of their courses, they do list OT as who the courses are designed for. And then I guess my only other caution is, yes, we do learn about CBT, we do learn about lots of techniques, modalities, but is the person asking, can they go out and use this as sort of their standalone practitioner approach? And I would have a concern with anyone who wasn't really trained in the area using that as their standalone and calling it OT, like going out and doing just that one thing and saying, yes, that's OT. I think like any other kind of OT, there needs to be that functional component that OTs address.
I think another concern with this course specifically, with this course specifically, is when you look at the objectives objective number 2 is assess for and diagnose each DSM-5 anxiety disorder, including, like, we don't diagnose, like OTs don't diagnose. Now we play a part in the assessment process, but we're not assessing in order to diagnose. And then, so if part of this certification is assess to diagnose to then treat, like that, that's outside of our scope of practice, I would say.
Yeah, but
So,
I mean, I don't mean to interrupt you, Glenn, but I feel like
sorry.
every course that you have like this talks about assessing and diagnosing so that you're aware of what components people must meet to be diagnosed for this.
Yeah, and I think from the academic perspective, I mean, that's part of what we do. We go through the
Right.
diagnostic criteria. We, go through the
Okay.
DSM-5 just to understand that process, knowing that we're not going to diagnose, but if you have a better understanding of what it takes, then that helps
Sure.
you better understand the condition, how to help with the condition, how to assess from an OT perspective.
Right.
So I don't think it would mean that she would then start diagnosing them. It's just a better understanding of it as a whole.
And it's
That's
common
Okay.
in all
I don't-
courses.
Those are learning
I don't
outcomes in our courses, it's the OTA.
Yeah, I don't disagree. Like, I don't disagree with that. I guess, like, because I don't know, I'm just, again, trying to play the devil's advocate there based on what I'm reading right there. Like, I understand this, like, after going through school and doing this and like the spirit of what we do as OTs, yes, that I totally agree with you there. I guess that would be my only caution is if.
Yeah.
I
I think
don't
Dr.
know.
Van, your response, I think I would personally like, and I think this is what Brenda alluded to, is like asking this person who sent you the email exactly what she's asking. Like, is she asking that this would be acceptable for her continuing ed and she would get credit for it? Or is she asking, from a supervision standpoint? Carolyn?
Okay, I guess my concern is, yes, our background is mental health. That's where we came from, but I think we have to be very careful in not crossing the line, because would we want counselors to be doing occupational therapy? So we have to be careful, I think, in terms of, staying on our side, and obviously collaborating with a counselor, collaborating with a physician, but because it's not specifically, saying directed towards occupational therapists, that's where my concern is. And I know that if, we're talking about in a perfect world where somebody would take the knowledge and, use it to supplement their occupational therapy practice, that's one thing, but we're not sure what is going to happen. And if something came up where she was outside of her scope of practice, but felt like she was inside, because she went to the course, then I think it could be a problem. We could be creating a problem, and she could find herself in some issues in terms of other professionals. I don't know how to word it, but looking more in depth at her practice to say, I don't think this is right. I don't know, maybe even affecting her ability to charge for some things, or coming back on insurance companies and them taking money back for a reimbursement because whatever she was doing didn't fall into the OT, scope. I'm just coming from a situation where something happened here at our autism clinic, and there was an issue about speech therapy and psychologist and diagnosing autism, and it was a big mess, I can tell you. So I'm coming from that point of view, that frame of reference, that you have your best intentions, but things could border on crossing that line.
Okay. I'm gonna go in the order that the hands popped up. Dr. Van?
I'm going to pass to Raylene for right now. I'm going to sit on, and Kelly, I'll make some comments to you. I thought you were wrapping up. Please
Okay.
go on, Raylene.
So I too work in mental health. This question has come up a lot, specifically within our program. There's been a lot of chat about this, and we have been told that there are two specifically related programs in regards to mental health certifications and occupational therapy specifically that are acknowledged. And that is AOTA used to have one, and that is no longer. I'm being told that they're working on it. I don't know what the projected outcome of that is, but there's also another one, and it just disappeared because my chart opened. There's another certification program by, it's going to make a liar out of me now.
Is this to be certified in mental health? Is that what you're?
Yes, and it's more global. It's not as specific as what this person is requesting. If that's what she's specifically requesting, I'm not sure. But I agree that this particular course is a little bit, the lines of that lane are pretty blurred. And then another point is, I'm not doubting that there's good information in this course that would be helpful for her in the realm of mental health. Might be good information to have in the back of her head. I oftentimes take courses that I'm not going to get credit for, or that I'm not going to be able to specifically use the technique, but it's just good information to have, to be on the lookout for. But in her documentation, in her approach, it has to be wrapped into ADLs and school-based
Right.
function, things like that. And so if you're specifically focusing in on things that are outside of that, it's a loss. You're
Just
getting
understand that this course was a sample course that I found through Tessie that somebody could take on this topic. She did not send us this course. It was one example. I literally Googled like OCD and ERP to see what would come up and if an OT could take that course.
right. So that would be my next question, is what course was she looking at?
Right,
I guess.
which gets back to the question for Dr. Van to really return to her and say, what is the intent? You need to know if you want to get credit for this course, or do you want to know, is it a supervision question? There's more information that's needed before we can say like, yes, you can do this, I would think. Kelly?
Well, I had very similar things to say as far as understanding the question. And also you mentioned going to courses that you use the information. It doesn't mean that I'm going to be acting as another practitioner, because I've gone to speech therapy courses and things like that, and use those techniques if it was for feeding or anything like that, just to help supplement. But I did, Darby, I sent you a mental health position paper, OT, and you probably already have it, but it does. It's interesting this came up because I had just registered for a course for pediatrics and trauma related issues, because it is more and more common. Our students are coming back saying that they need more information about it. It's just the world we live in right now, where we're really addressing mental health and all, across the board, more intensively, not just in a mental health setting. And so that's what I was just going to say, is I really would like to understand more of her question. I mean, I do plan on going to a course about trauma and mental health and anxiety issues, just to help me understand, help teach my students also, because those techniques are just valuable to have. But that was it.
Okay, Dr. Van? You're on mute. You're on mute.
I think I can write the letter, Darby, with your help, and we'll get the information that you all have asked us to glean in this matter. We can advise her that the board doesn't approve courses, the AOTA or the LOTA approves courses. But we want to understand what she plans to do with the information out of the course and what course is she going to take. Because I think we've all agreed that we don't need OTs functioning as standalone therapists for OCD.
No.
And so, look, let me say this to you. Let me just tell you two quick stories. Number one, I tell everybody I spent 4 years in medical school, and 3 years of residency and 1 year fellowship. And all of those years required me to become very OCD to be able to be competent to get through what I had to do in the 1970s. And I spent years afterwards going to therapy to stop being OCD. So I understand what we're talking about, but sometimes OCD is a good coping mechanism. The other thing is, we as a nation just do not have adequate mental health providers. And what I don't want to have done is say, you all are becoming mental health providers in the face of the board saying, wait a minute, they shouldn't be mental health providers. They should be OTs that have some skills in mental health and utilize those skills to best treat the patients in an occupational therapy setting. So that's why my concerns are, look, I have a daughter with adult mental illness and I live with it every day and I understand what you all deal with. So I want to make sure that we protect the public in whatever we decide, and we can find out more about the course. And what I'm happy to do is draft a letter with you, Darby. I'll start a rough draft and send it on to you, and then you can correct my punctuation and bad language and address the bullet points together, and we'll get it back together.
Yeah, I mean, I just feel like at this point, like, I don't want to recommend anything. I just want more information of where she's coming from, whether it's really just she wants credit for the course, she plans to practice. I mean, I have questions, I guess, about her supervisor, if just anything and everything like that. And I didn't mean to cause confusion by sending this course, but I was just like, is there a course that we could take on this that would already be approved? And what is it like? And I just wanted to share that with y'all because it was sort of a last minute addition. So yeah, and then also information to Dr. Van for, from AOTA of this does cross into our scope of practice, but it doesn't specify, how much and what and how to make it functional and within the practice setting. So we will work on that. Does anyone else have any comments or questions for this, for the return email? Nope. Okay. Dr. Van, do we need a motion to?
No, I think we got. I don't know that we got I think we need there's no motion. You just need further clarification before you can make a motion. You and I will obtain that clarification. And let me just check real quick to make sure we don't have any public comment.
Yes, please.
There.
And I forwarded you the document that Kelly sent us, just so everyone has that for
Okay.
information. Thank you, Kelly.
Okay, as soon as I get that, I'll make sure I get it. So we're going to go ahead and write the letter requesting more information, and that's really all we really need to do at this point in time. And again, like I said, since we really are redesigning the rules, I want to make sure we address what I know is going to be the concerns of my board in terms of the psychiatrist, the two psychiatrists, one of whom is a child psychiatrist. Okay. So we'll get that done. And you want to move on to,
Yep.
We don't have an executive session, so let's go back to the rules.
Yeah. Does anyone want to take a break right now real quick before we dive in? Y'all good to go?
I think if somebody could give me sharing, or let me see if I can share. I can share.
So let me stop my share and you can start your share.
All right, so let me pull up the rules right here. Can everyone see that? The rules that I've just put up, am I sharing the right screen?
Yeah, I'm seeing them fine.
Okay. All right, I just got to pull way down. We have made progress. We're way down here.
I think we are on, is it 4925? That's what pops in my head, but.
We're at OTA, I know that. Here we go. Discontinuation.
4925.
4925, yeah. Supervision of occupational therapy assistants. This is where we're at.
Okay, so Dr. Van, we, meaning Ingrid and I, sent to the committee examples of other states and sort of like loosely assigned people to certain states to review specifically what their rules stated. Now, we don't know if, they've all been updated or whatnot. So I just kind of want to give you that background. And Olivia shared that document in this link, in the cloud share link. And Ingrid, we didn't really discuss like how you want to go about doing it. Should we read ours first and look at other states? Like,
I'll start because I created a summary and then maybe others can follow something similar. So I looked at North Carolina and just as a summary of the differences between them and us currently, they do not have any differentiation for OTA supervision based on the years of experience of the OTA. They don't have any of that. They do not have any supervision differences for OTAs based on the setting. Every setting is treated the same. They have one definition for supervision of OTAs, and it's called general supervision. It's a very long definition. General supervision has to occur at least monthly, and all methods are allowed. In person, phone, video, demonstration, collaboration, there's no restriction about how you do this at least monthly supervision. It can be virtual or in person or over the phone. The OTs have to do an intervention review and of each client who is being seen by an OTA. First of all, I like that word because we've had a lot of problems with the term reassessment, and they call it an intervention review. So the OT has to do that for every client who's being seen by an OTA. There is no frequency given for that. They don't have anything about the OT has to review the intervention plan of any patient being seen by a CODA every 6th visit or every month or anything. Now, the OT has to supervise the OTA at least every month, but there's no frequency or time frame given for this intervention review. So that's the summary of North Carolina.
so the other thing about North Carolina that I did like is that they did say video conferencing is not allowed for direct supervision.
Darby, you got really quiet. What was that?
They did say that video conferencing is not allowed for direct supervision. So they gave some parameters of that.
Direct supervision is actually not related to OTAs at all in North Carolina, but only to unlicensed personnel like techs.
Right. So and that was my other thing, that they named text and age, which has come up in a couple of things that we talked about at LOTA, because not many of these states mentioned anything about aids and text. And I think that might be something that we need to consider.
I agree that they differentiated between supervision of an OTA versus supervision of a tech. There's all different rules and different terminology for it.
Yeah. And they also named an OT practitioner. So I felt like it had kind of been updated. And I think this one state is the one that most looks like the guidelines from AOTA.
Okay.
So I don't know, I felt like it was probably one of the ones. They also mentioned something about co-signing, which is something else that we might need to consider whether or not it's required or not. Like it specifically states what needs, that co-signature on OT services documentation.
Actually, what they said was presence of a co-signature alone does not necessarily meet
supervision.
A supervision requirement.
Yeah.
That it needs to be apparent in the documentation, and then that just the OT co-signing a note is not enough.
Yeah. So all things to think about.
Does somebody else want to sort of summarize their state that they looked at?
I looked at Florida, and which surprised me that, and I guess maybe it was an older update. Not a lot of detail, simply a definition of what an OT assistant is and a definition of what supervision is, and very, very vague.
Okay.
I was kind of wondering if Florida maybe had their supervision stuff in their practice act, because it was so vague.
I know, and I tried to dig around to find more details, like in other documents and such. It was not very user friendly to try to dig around, and I couldn't find it.
Yeah. One of the things that they did say was that the supervising OT need not always be physically present or on premises when the
Right.
student is performing services. So I was like, that's very vague. Too.
Yeah, like I said, it surprised me how vague it was.
Yeah.
Okay, so it doesn't sound like we want to copy Florida.
I'd go with something a little more specific.
And
All right.
I'll do, Kim is not here, right? Kim,
Kim is not here.
so she had Arkansas and she didn't give me anything, but I just I looked at them kind of all last night and just took some notes. But basically the things that stuck out to me is that theirs is saying that the supervision shall is always required, even when they're highly experienced in a particular area, which I felt like was really good because some of the states break it down. Like if you're an assistant, like with more than 3 years of practice, you need less supervision, but this specifically states that no matter what, you always need supervision. So I felt like that was like very good. They talk about the frequency, but it says that the supervising therapist is on site face-to-face for a minimum of 1 hour per 40 OT work hours. And that's how they break it down. So, and some other states did that too with like 1 hour per 40 work hours. I think it's, different than ours with a percentage, but some states did do that. Another thing that Arkansas mentioned was that each occupational therapy assistant will maintain for a period of 3 years proof of the supervision log, should it be requested by the board for audit. So it put that log on the assistants to keep it, and it specifically stated that they had to keep it for 3 years. And then they kind of went into other things like, the rules with like assessment, the treatment planning, intervention, documentation, pretty similar to ours. They had their last thing was in the extenuating circumstances when the OT assistant is without supervision. The OT assistant may carry out established programs for up to 30 calendar days while appropriate OT supervision is sought. So I didn't really like that, but it's in there. And it should be the responsibility of the OT assistant to notify the board. So in some of the states, you have to get board approval to even have an assistant and who the assistant is, which I thought was very interesting, but not something I'm suggesting. Just kind of throwing that out there. So those were kind of the notes for Arkansas, mostly the one that's like a 3-year proof of supervision log, because I don't think we have anything in our documents about that and who's responsible, but Arkansas is face-to-face. So for that 1 hour per 40 work hours.
I had Texas.
Okay.
They do not have really specific rules for a regular license. Temporary, there are specifics, but for a regular license, they're no longer required to submit a supervision form, no longer required to notify the board of supervisor changes, and no longer required to receive specific supervision hours or maintain a supervision log. That's with a regular license. There is something as far as their role throughout the OT process. It is very similar to Louisiana. One thing that I noticed was in the documentation, in each intervention note, the OTA must include the name of the OT who is readily available to answer questions about the client's intervention. And it does not have to be the one who wrote the plan of care. So whoever's responsible, they do have to write the OT in the intervention note every time. They do not have to co-sign it.
Hold on, Kelly, real quick. So each time the CODA writes a progress note or any intervention note, they have to list the name of an OT who had been available to them that day.
Yes, or there, it just says who is readily available to answer questions about the client's. I made a PowerPoint if you want me to send it to you. That's the teacher in me. I'll send it to you with all the like highlights. So that,
I like that.
Me too,
kind of,
that's
you know, stood
interesting.
out. Everything else was really very similar as far as the plan of care. It didn't go into, but it never really mentioned specifics about, didn't differentiate settings, number of hours, years. I know that they can work in home health as a new grad, so that's a little bit different than us because we have a new grad that's now doing that. So I contacted 2 CODAs also in Texas and asked them, and you know, the only thing that really stood out to them was that they had to write the OT and the documentation. There are very, you know, specifics on temporary license, but that's a given.
So Kelly, in Texas for the regular permanent license, there's no differentiation on supervision levels based on setting. Is that what you're saying?
Right, on based on setting or based on experience.
Or based on experience? Okay.
Or,
Right.
But
One-
one thing that I really liked, because we do a lot of this in school and practice groups, is general purpose occupation-based instruction. And this is just in general, this isn't just OTA, but OT practitioners may develop or facilitate general purpose occupation-based groups or classes, including but not limited to handwriting groups, parent-child education, wellness-focused activities, aquatic exercise groups, cooking for diabetics. They just have some examples. These services do not require individualized evaluation and plan of care services, but practitioners may develop goals or curriculums for the group as a whole. And it says, when general purpose occupation-based instruction is provided, the OT must approve the curricular goals program prior to the OTA's initiating instruction. I like that little addendum there that they had. It was a whole other section. But really that was, yeah.
One thing that they did say that I thought was interesting is that if you look under plan of care, it says devices that are in sustained contact with the client, including but not limited to wheelchair positioning devices, splints, hot cold packs, or therapeutic tape, require on-site and attending presence of the occupational therapy practitioner for any initial application.
Yeah, and I didn't know if you wanted me to talk about that because it was I mean, it kind of was like, well, surely the OT would be there to do that with the patient, the OT practitioner, because it was OT
Yeah,
or OTA.
yeah. Well, it just
Um,
says that after that, then it's like the OT practitioner, like determining on-site and attending for subsequent applications or modifications, you know, is up in the air, but it just specifically said that, and not many states like get that specific with like taping and hot cold packs, you know, it kind of gets more into the modality world, but
Yeah.
felt like that was kind of
True.
interesting.
All right, good, Texas. Who else do we have?
Oh, and they do not have service competency forms.
Excuse
No.
me? They
No,
don't
they
have
do
what?
not have, I mean, that I could see. It just says the supervising OT may only delegate to an OTA tasks that they both agree are within the competency level of the OTA. So it wasn't like a specific form that had to be completed. It just, they have to agree that they both can do, you know, feel like they're competent to do it.
I'm sorry. So the competency, there is no competency form. Is that what
Right.
you're saying? The
Right.
OT and the OTA simply agree that the OTA is competent?
Yes.
And they also allow for contact with client during the intervention session via telehealth.
Mhm.
using synchronous
Yeah, I have a
audio.
telehealth slide. Yeah. And the clients, the OT rules do not require that they be in Texas at the time. But the client must be located in Texas. It can be used for mode of service. Yeah.
Kelly, I didn't quite understand what you were saying in Texas in terms of the OT. So if the OTA is competent in a modality and the OT is not, is the OTA allowed to do that modality?
It just says, well, it doesn't specifically talk about modalities. It just says any task. Like when we're just talking about service competency, it just says the supervising OT may only delegate to an OTA tasks that they both agree are within the competency level of the OTA.
Okay, so it's within the competency of the OTA. Got it.
I mean, they do talk about, like Darby said, about initially. Oh, and they also, back to referrals, they don't, the evaluation or intervention for a non-medical condition does not require a referral. And a non-medical condition is where the ability to perform occupational roles is impaired by developmental disabilities, learning disabilities, aging process, sensory impairment, psychosocial dysfunction, or other such conditions that do not require the routine intervention of a physician. I liked that too, because that happens a lot in peds. We see them forever, and they might not be under the direct care routine, but they have a developmental disability.
And,
I can send you this, Ingrid.
yeah, that'd be great.
Okay.
Who do we still have to hear from? Glenn, did you do a state by any chance?
Yeah, Massachusetts.
Okay, what you got?
They have a lot. They do a good job, I think, of setting up some definitions, talking about the OT therapy service delivery process, and what's different between OTs and OTAs. They focus a lot on OTs, which is good. But when it comes to OTAs, what I noticed is that there's not like the specific timelines for like how long you have to be supervised, or like how long you have to work in a certain practice setting before you're not supervised. Like anything like that. They don't have any timetables for OTs or OTAs, nothing like that. When it comes to, they do talk about like supervising personnel, but my interpretation of it is that they say that any services that, this is me summarizing, but like any service that is supervised, it rests with the supervising occupational therapist. But they do kind of get into, they say this part, that occupational therapists and occupational therapy assistants must exercise their professional judgment when determining the number of personnel they can safely and effectively supervise to ensure safe and appropriate care is provided at all times. I think that's good, but I think when they're talking about personnel, let me see if they define that, because they do have some that's not defined, but I think when they're talking about personnel, what they're meaning is occupational therapy aides, like the therapy techs of the world. And so then they talk about these other things too. And the way that this is written is that it alludes to these therapy techs or these occupational therapy aides are documenting, and then that documentation has to be co-signed by an OT or an OTA. Now, I haven't worked in a practice setting where a therapy tech is doing documentation that I have to sign off on. I'm not saying that that's not done and done somewhere else, but maybe somebody else can speak to that.
Wait, are you saying an unlicensed person is doing documentation?
So this is it is written this way. If you're looking at the Massachusetts thing, it's 3.04 co-signing of documentation.
And they're talking about unlicensed personnel, like techs.
It says the supervising occupational therapist or occupational therapy assistant must co-sign the documentation of occupational therapy aides.
Oh Lord, we're not going there.
I know, I'm just saying, like.
Yeah, no,
but they have it written there. So
that's just one of my gut reactions. I do not want unlicensed personnel documenting at all.
No, I wouldn't either. but they have it written there. So, I mean, I
Yeah.
don't know what they're doing. So I guess just don't get hurt in Massachusetts. But anyways, those were some of the things that kind of stuck out to me. I mean, read it over. I guess my CYA to the summary is read it over personally and make sure that if there's anything else that you like or don't like, then I guess bring it up. But those were some of the things that kind of stuck out to
Did
me.
you note whether there's a specific frequency that the OTs have to review documentation or review the
No.
plan of care that an OTA is involved in?
No, I don't see. I don't see frequency. I don't see timelines. I don't see anything with a number attached to it. It's
Okay.
just that if there's supervision, it needs to be documented, and that supervision ultimately falls on the OT. Like that's my summary of it.
The only thing it mentioned, Ingrid, is that the supervision may necessarily be more frequent than the minimum required by the practice setting or regulatory agencies, depending on, and then it talks about like unpredictability and complexity, the number of clients. So that must be listed somewhere else, because it says about regulatory agencies. I don't know if it's just the payer.
I don't know of any regulatory agencies that get into how frequently an OT needs to supervise an OTA.
Yeah.
I mean,
That's all it said. Dr. Van,
Right,
you have something?
Oh.
You're muted. You're muted.
I have the Massachusetts document up. If you want me to show it to y'all, could see exactly what he's talking about. I have those documents. They're actually in the agenda that y'all sent me.
Yeah, that's what we're looking at.
Yeah.
Glenn just reviewed them, so
Okay.
thank you.
Okay, so let's see. Raylene, did you also review a state?
I did. And similar to Massachusetts, Alabama kind of groups aides and assistants and students all together. It kind of gives this global statement that the occupational therapist is responsible for supervising the occupational therapy assistant, as well as the aide and student. That's in their practice act, as well as this the document that was attached in the email. It does decipher between direct supervision, close supervision, and general supervision, which I liked. It was very kind of specific. Direct supervision is supervising occupational therapist is in the immediate area of the occupational therapy assistant while performing supportive services. Close supervision is the supervising occupational therapist provides initial direction to the occupational therapy assistant and daily contact while on the premises at least 50% of the OTA's direct patient care hours per month. And then general supervision is the supervising OT has face-to-face contact with the OTA at least once every 30 days with the supervising OT available by phone, electronics, or written communication. So I thought that was interesting. The OT can only have 3 full-time OT assistants under their wing at one time and no more than 2 that are under direct supervision. So that leveling system becomes super important. They did specify, it was in a different place, which I thought was strategically weird. They did specify loosely length of time in each of those stages. So direct supervision is defined as at the discretion of the OTR itself. Close supervision is if the occupational therapy assistant has less than 12 months experience. And then general supervision is if the OT assistant has more than 12 months experience. And then if the setting of practice changes, the level of supervision increases, which I liked as well. If the OT is working part-time, they should have no less than 1 hour of direct supervision per calendar month. And if the OT assistant who works with more than one employer must notify the board of the supervisors for each employer. So that was a general summary, but then also when I was kind of cruising the Practice Act, I found something. This has nothing to do with supervision of OT assistants, but they have a occupational therapy wellness committee for impaired practitioner programs. And I just thought that that was pretty cool. I had never seen that. I hold a California license as well as an Arkansas license, and I've never seen that. So I just thought, for if anybody needs a lot of reading material, it's good reading material to hang out with on a Friday night, I guess. So that's it.
Love it.
Well, it sounds like Alabama's rules are very much like our current rules, with a lot of supervision requirements based on level of experience of the OTA and differing per setting.
And it was very
those-
easy to find. Like on the website, it was super easy to find, super accessible. So I appreciated that as well.
The other thing that I thought was very interesting in theirs was that it has this weird thing. I'm sure, Raylene, you saw it, but it says for OT assistants employed by state agencies and those by public schools and colleges who provide screening and rehabilitation services for the educationally related needs of the student. The direct and close supervision mandate based on work experience does not apply. In these instances, supervision should be at least general, which, to go back to the definition, like the general was face-to-face contact and at least every 30 days.
Right.
So that was just interesting that they kind of, I'm always looking for like these like weird things, because we have them in ours too, but like, and also the schools, right? Because that's been an issue for us of the schools. So they kind of have like this different thing for schools and colleges, whatever. So that kind of caught my eye too.
Yeah. Sure.
Carolyn, did you have an opportunity to study a state?
I did. I had Virginia, and it was not a whole lot of information that differed on the website and in their Practice Act or in their rules and regulations, other than what AOTA provided. But there were some things that I have highlighted and thought they were worth mentioning. And they have the same thing that Massachusetts had about the occupational therapy personnel. They kind of group OTAs and techs together. It seems to be because they give a definition of an occupational therapy assistant, but then they talk about occupational therapy personnel, which doesn't mean anything right now until you get down to the supervision. One of the things that they say are is that frequency and the methods and the content of supervision are really dependent on the complexity of the patient. And so, that's giving some leeway, I guess, in terms of determining how much, like whether it's close or direct or whatever. And also the competency and experience of the assistant. And then they put some of the emphasis on the practice setting, I guess, I don't know, types and requirements of supervision for the practice setting. So some of that is just super vague, and it leaves a lot of leeway for interpretation. So the OT that's providing clinical supervision shall meet with the OTA to review and evaluate treatment and progress of individual patients at least once every 10th treatment session or 30 calendar days, whatever occurs first. And group treatment sessions are not, they're not any different as individuals treatment sessions, so they would still count in that. The OT, I thought this was interesting because I've had a lot of people ask me this question over the years. How many OTAs can an OT supervise? And they specifically say no more than 3 OT assistants at any one time. They can supervise up to 6 occupational therapy personnel, but no more than 3 OTAs. And then the OTA has to document in the patient record any aspects of the initial evaluation or treatment plan, discharge summary, or other notes on patients performed by the assistant. So they can do those. And I know we have quite a bit of people asking, like, what about discharge summaries? There seems to be a lot of confusion about who has to write the discharge summary in Louisiana. But the OT shall countersign such documentation in the patient record at the time of the review and evaluation required in an above section that we just talked about. So that's really all that was in there. One thing that they did point out, this doesn't have to do with supervision, but if somebody is under a temporary license, they have the person to sign as occupational therapist license applicant. They have to include that in their signature. I thought that was kind of interesting.
Yeah,
But that's all that there was.
Carolyn, could you just back up a little bit? You told me that the OTA is the one who has to document what?
The occupational therapy shall document in the
Wait,
patient
OT or
record.
OTA? I'm sorry.
OTA.
OTA shall document.
They any aspects of the initial evaluation, treatment plan, discharge summary, or other notes on patient care performed by the assistant.
Okay, so if the assistant has been delegated to do a piece of the initial eval, like a standardized assessment, then they need to document that they completed that part.
Yeah, that's what it sounds like to me.
And the
But that-
difference there that Caroline's saying is it also includes a discharge summary, which for Louisiana, we don't specify who can do that, but it looks like they can.
Our current rules, we don't even specify that you have to write a discharge summary. We just say that you have to have documentation somewhere that you've planned for the patient's release from your services, but it doesn't have to be called a discharge summary.
Yeah.
Right. So, but the OT does have to countersign. So on those documents.
Okay.
And I have it typed up and I can send it to you if you want me to.
Thank you, Carolyn. And as far as, because I'm just trying to get some commonalities, just to regroup on, there's no specific differences in supervision level based on setting or based on years of experience of the OTA.
No, there's not.
Instead, the emphasis on that the level of supervision is I guess almost like a clinical decision of the OTs based on the complexity of the patient and based on how competent and experienced the OTA is.
Right. And any requirements of the facility, probably based on insurance reimbursement. That's what I would figure.
Okay.
I mean, it does say demonstrated competency, but there's no like mention of like a care plan, I mean, a checklist.
There's no
or anything.
competency documentation.
Not that I saw.
Not that I saw either.
Okay.
I was just wondering how they define demonstrated competency, but it's not defined. I'll do West Virginia. That was Amy's. I don't know if everybody else is, but yeah, I did mine. So Amy had West Virginia since it's right underneath it. And Ingrid, I just went through and highlighted all this stuff, so I'm happy to send that to you too, like things that like stuck out for each one. So West Virginia they have definitions for direct supervision, which means actually physical presence is what they said. And that's the delineation of tasks and responsibilities, personally reviewing and interpreting the results of any habilitative or rehabilitative procedures, conducted by the limited permit holder, occupational therapy student or aide. So again, all of those are mentioned. And then it said direct supervision includes direct close supervision and direct continuous supervision. So direct close supervision means that the licensed supervising OT or OT assistant is in the building and has daily direct contact at the site of work. I guess that would exclude any like telehealth or things like that. And then direct continuous means that the supervising OT or OT assistant is physically present in indirect line of sight of the OT therapy student or aide. So that direct continuous.
So these are the supervisions for techs and students.
Well, it's both, right? So like direct supervision could be all of them, but the direct close could be, it says assistant, and then direct continuous would be the student or the aide. So they kind of list each one in the thing.
Uh-huh.
I mean, it's saying like you can have direct supervision of a student or an aide. They don't define the student or aide, but they do define an assistant. That's just saying that's licensed, the same as ours. And then they talk about requirements. For the assistants specifically, they have general supervision, which means initial direction and periodic inspection of the activities of the assistant, but does not necessarily require constant physical presence on the premises. So that would be just specific to the assistant. And then it's only that one, just general supervision. And then it says that the assistant means that they're licensed by the board. Then they have a section on responsibilities of supervision for OT, OT assistant, or licensed permit holder, which I'm not sure what that is. Guess that's maybe a tech. And then it just goes into face-to-face visits during the initial eval, establishment of the plan, change in plan, adding, changing, renewing, or discontinuing OT goals. So the therapist, the OT has to have that face-to-face visit. And then it says the assistant's responsible for delivering the services under the supervision and in partnership. Then it's on the responsibility of the OT to look at complexity, number of clients, skill, practice setting, requirements, and other regulatory requirements. And then the other thing that kind of stuck out to me was that general supervision is demonstrated through co-signatures on all paperwork or electronic notes for a person that requires supervision. Everything must be signed and dated electronically or otherwise by the supervising licensed OT. They do not need to be present or on the premise at the time where the assistant is performing the professional services. There's a lot of like gray and loop areas in this.
So in West Virginia, are there differing supervision levels for the OTA based on their years of experience?
Nope, no mention.
Are there differing supervision requirements based on the setting they work in?
No, I mean, it mentions setting, but it's at the discretion of the OT.
Okay, so that's all. And then do they have any sort of frequency of how often the OT has to supervise the OTA when the OTA is working with a patient?
No.
There's no frequency or frequency.
No, it's all in the responsibility of the OT, it says.
So they have all these multiple definitions for supervision levels, but they don't actually say when they're used.
Nope.
Okay.
Wait, it does say that yes, it is. I'm sorry, with less general supervision is less than 1 year experience. With direct contact at least every 2 weeks at the site of work. I'll read you the thing. It's the responsibility of the OT supervising and OT assistant with less than 1 year experience to provide general supervision with direct contact at least every 2 weeks at the site of work and supervision available as needed by telephonic, electronic, or written communication. Documentation by the OT must reflect that this has occurred. So it's only with less than 1 year experience.
And after the OTA has a year of experience, then what's their supervision level?
It just-
General, but without the contact requirement?
Yeah, it just says with increased skill development and mastery of basic role function, general supervision with monthly direct contact and supervision as needed.
Monthly direct contact.
Yep.
So,
And just as needed by telephonic. I don't know why it doesn't say telephone, it says telephonic, electronic, or written communication. And the documentation has to reflect it.
okay,
So every 2 weeks for less than a year, and then after that, it's
monthly contact after that.
monthly.
Okay. Did we hear from everybody?
And I haven't given mine,
Okay,
which is, what is mine? Arizona. Arizona. I'm scrolling, sorry. So they define close supervision as, it just says close supervision means the OT provides initial direction to the assistant and daily contact while on premises. Continuous supervision means that the OT is in the immediate area of the occupational therapy aid performing supportive services. So the continuous would be the aid, not the assistant. Then general means supervising has face-to-face contact at least every 30 calendar days on a per patient or client basis while on the premises, available by telephone or written communication. Minimal supervision means the OT has face-to-face contact at least once every 30 calendar days while on premises.
that was the same as general.
Um,
Oh,
Well, only-
but the general was also included, the
phone and written,
phone and written. Mhm.
yeah. And then routine means that they have face-to-face at least every 15 calendar days. Also by telephone or written. And then it says supervising OT shall supervise an assistant as follows: not less than routine if they're less than 12 months work experience in a particular setting or with a particular skill.
So if an OTA has 3 years of experience but goes to a completely different setting, then it's like they're a new grad again and have to go back to routine.
It's worded with that for every single one. So it's like less than 12 months in a particular setting or with a particular skill.
Okay, well,
And
that's-
then if it's between 12 months and 2 years, it's general supervision for less than 12 months or 2 years in a setting or with a skill. And then not less than minimal supervision if they have more than 2 years experience in a particular setting or the particular skill.
Okay, so less than 12 months is routine, between
Yep.
12 months and 2 years is
General,
general, and greater than 2 years is minimal.
minimal.
Mhm. Okay,
So, I mean, something for us to think about with years of experience or setting or skill.
I do know that the AOTA would rather we not, they would rather we follow North Carolina and Texas's example and not, come up with numbers.
Yeah,
And I personally feel like CODA education is excellent. And that they graduate and pass their NBCOT exam, they should be allowed to practice.
yeah.
But based on the states we all looked at. I'll start with just, well, but the concept of
Ingrid?
Uh-huh.
This is Brenda. If I could throw out there too,
Yes.
I didn't specifically look at it for this, but I am licensed also in New Mexico.
Mhm.
And in theirs, they don't speak to numbers, but they break down tasks. And so like who has what role in evaluation, who has what role in intervention. So they take it from that perspective versus numbers. So just something else.
Yeah. Which I think we were trying to do.
Mhm.
So let's see, just as a overall, we started out with, in terms of, do these states have differing supervision requirements based on the OTA's level of experience? And we had North Carolina, that was no, and we had Florida, that was no. We had Arkansas, that is a no. We had Texas, that's a no. Massachusetts, no. The only two states that have differing supervision requirements based on the OTA's experience were Alabama, West
Arizona.
Virginia, and Arizona.
Yeah.
But the majority have moved away from that. And I know the AOTA wants us to move away from that, and so that's something to consider for us. Then we have, is there supervision differences for an OTA based on setting? And I believe it was only Arizona that had that, right? Because they have if the OTA moves to a new setting, they have to get more supervision again. And other than that, I think they were the only one that had any supervision differences based on setting. So that's something for us to consider, because we have a lot of differences in supervision based on setting.
Yeah, I mean, there's somebody else kind of mentioned it. I can't remember who it was, but it definitely was, I didn't really see much, if anyone else did, about like home health, which is where we like definitely get super strict on. Like I kept looking for home health and I did not see it.
No. And the home health requirements are, our current ones with OTAs are completely onerous and not really doing anything for the public safety.
Right.
Okay, so we basically are, that's the OTA based on years of experience or setting. Another thing we were kind of looking at, trying to find commonalities, was how often does the OT need to check in with the OTA? That varied a lot. North Carolina said every 30 days at least.
Yeah.
Let's see. Florida was vague. Let's see, Arkansas. 1 hour of on-site face-to-face for every 40 hours worked. So that one was pretty frequent, that they have to check in and be with the CODA on a general work week. That would mean once a week per
Right.
patient. That was Arkansas. Texas. I don't think it looked like no longer submit. They, in each note in Texas, the OTA has to name the OT that was available to them during that treatment session. But unless I'm wrong, Kelly, there was no other specifics about frequency of OTs supervising a CODA in Texas.
Not with not fully licensed, regular license now. Just
Yeah, fully licensed. Okay. Same with Massachusetts. There were no frequencies or timelines on how often the OT supervises the OTA. Alabama has a lot of rules. at their most loose, which is called general supervision, after the OTA has 12 months of experience, then the face-to-face has to happen at least once every 30 days.
They also mentioned a new practice setting, and they also do something separate for schools.
Alabama.
Yeah,
Okay, so they also has practice setting thing. So if that's 30 days, then we have Virginia, which they have to meet with the OTA at least every 10th visit or every 30 days, whichever comes first. We are seeing 30 days as a commonality here on the ones who give a timeline at all. West Virginia. Once the person has more than a year of experience, then the supervision is monthly. And Arizona, once the person has more than 2 years, and assuming they stay in the same type of setting, they would stay at the minimal, which is a face-to-face every 30 days.
oh wait, go back to West Virginia, because West Virginia also had less than 1 year is every 2 weeks.
Yeah, no, I was trying to go by, if we pull experience level out.
Oh, gotcha.
And
Yeah,
so I was looking at just like, once somebody has the experience in these states, what are they what are
Yeah.
they doing? And it's every 30 days.
yeah, it's monthly.
I
They just
would
say monthly.
say that the majority of the states do have a frequency of contact between the OT and the OTA of every 30 days. And there's only a couple of states that do not specify a frequency at all. That was North Carolina had a frequency of every 30 days. Was it Texas and Massachusetts? Might have been the only two that
Massachusetts
specify
was-
no.
I think Massachusetts was the one that was like, didn't require very much.
Yeah, Massachusetts had no frequencies, and
Like
Neither
no
did
documentation, like,
but every other state had at least of every 30 days. So I just wanted to kind of like have some background informing of what other states are doing, but I think we should go through our thing in order. We may change the order later, but I think we should kind of do what we've been doing. I'm looking at 4925A and starting there, and then talking and changing based on what we've learned. Is that okay with everybody?
yeah,
Okay. I know I need to take a break.
Yeah.
Before we get started. So should we come back in say 10 minutes?
yeah,
Okay, so that would be
That'd be-
12:58.
yeah.
I mean
right before
11:58.
11. And then we have 1 hour to go through it, so
Yeah.
sounds
So
good.
we'll come back at 11:58.
Okay, great.
Ms. Darby,
Yes, sir.
to this point, you've had no public comments.
Okay, thank you.
Okay. Well, I guess we're probably all back.
Yeah.
Okay. Well, let me make this a little bit bigger. So we're looking at our rules here. The rules of this section govern supervision of the OTA by a supervising OT in any clinical setting. So the part B talks about that the OT can assist in the implementation of the client program plan in consultation with the OT. Did we not cover this earlier when we started talking? Didn't we kind of put that stuff earlier under the eval part?
That's what I was just looking for. Yeah.
I think we did when we went through the OT process and talked about the role of each and in each step.
We gotta find it. Yeah, it's in that, I think it's in the intervention process 4913. Is that what you're talking about, Kelly? Where it says like they have the overall responsibility, blah, blah, blah. Wait, where's the part about the OTA?
When delegating, we wrote it as when delegating aspects of the intervention process to the OTA is responsible for providing supervision as stated in section 4925, which is what we're working on now.
This is a little bit different though, Ingrid, because it kind
Yeah.
of gets into physical presence and
Right. So we did, in this section, we did already delineate what the OT can do and what the OTA can do about the eval.
it's more like task specific.
Mhm. So such supervision shall not be construed to require continuous physical presence. However, the supervising OT and OTA must have the capability to be in contact with each other for discussion. Supervision shall exist when the OT responsible for the client gives informed concurrence of the actions of the OTA and adheres to all requirements set forth in this chapter. So I guess B is like a general global definition of what this would mean in Louisiana by supervision without getting.
But I feel like with it naming stuff about like the telephone and things, like it can cause some confusion because we get specific in other parts.
Yeah.
You know, like require the physical presence. Well, that may only be in specific parts of supervision.
I'm not sure we even need this paragraph. Feels like we would just get into, you know, what we specifically mean.
I think some of it's covered in other parts, and I think some of it makes it more confusing because if it says things like telephone or telecommunication, and it's not specifically talking about the types of supervision, or if we break it down into like settings or something, then it's going to be confusing.
Yeah. Let's look at what comes up next with C.
Mhm.
prior to implementing a plan, prior to the administration of OT by an OTA, the OT shall perform an eval, establish the needs and goals, and ensure that the documents are made part of the client's record and accessible to the OTA, and have to be available for a client care conference. I would, I personally don't have a problem with how any of that is phrased, except for possibly number 3. Sometimes after an OT has assessed a client, they verbally have time to talk to the OTA about the client and give direction on where they want the client to go, but maybe have not yet actually finished up the eval and gotten it in the chart.
Yeah, and that's when I mean, that specifically is addressed in that rules and laws thing.
I mean, I
Yeah.
get that, but it's also a slippery slope of if we don't put a time frame on there, how long are they gonna go off the verbal, hey, this is what you need to work on? Because
Mhm.
we really
Okay.
are pretty adamant about making sure you understand or know, have read the eval, know about the client, know what the goals are, because you have to know what you're working on, and not coming up with it just because. So I don't know. I kind of like it. I know it's hard. I'm an OT. I get it. But what do you say after before the second one, they have to have it? I don't know, because they could
Yeah.
just do that for.
You're right. No, you're right. That's why we're talking this stuff out. No, you're right about that.
Because we've had students come back before and say they never even laid eyes on it. They don't. These are students, but still, they should have the
Right.
evaluation, and they have never even seen the goals.
Yeah.
Now, let me ask you this. Does the way this is written feel like it would be almost a contradiction of what we say earlier? Earlier, we say that the OTA can collaborate with the OT on delegated pieces of the eval and of developing goals in the treatment plan.
Mhm.
Then here it makes just the phrasing of it makes it sound like it's
Well, I don't think it's contradictory because it says
Okay.
prior to implementation of the plan, whereas before they're just collaborating on the evaluation aspects of it. And if, they're going to participate in any of the assessments or collaborate on some possible goals.
okay.
I mean, I don't know. What else? Anybody else have a?
Well, I think number 3, when you were talking about it, Kelly, like it's also like if you think about the practicality of it, and I mean, I'm open to other people who's supervising, but like you can tell them specifically like what to do in that first treatment session, but without the whole assessment, they're not going to have the whole picture.
Right.
It's like, this is what we're going to do today. But without having read that whole assessment, I think they're not getting the whole plan.
Mhm.
I'm trying to see if it's contradictory, because that's exactly what we're trying not to do.
We could say perform an evaluation as outlined in section. What's a what?
Yeah.
So that somebody goes back and sees, oh, well, an evaluation means this, and it means that the CODA can be provided with delegated tasks.
And I guess my other question is this still in accordance with the standards of practice?
Is it what now?
Like where it says like the supervising OT shall, in accordance with the AOTA standards of practice, from time to time be amended. Like,
I don't even know what that means.
This
the way, in accordance with AOTA standards of practice as may from time to time be amended.
Yeah,
Oh, standards of practice as may from time to time, okay.
yeah, you see how it's kind of like, wait, what, like, have we kept that up to date as well?
Yeah, I'm just flipping through the,
And I guess the other question is, are we planning on keeping the client care conference? Since other states didn't, like, is that something that we feel like we need to keep in there?
um,
I think
I-
so.
I don't think so, actually. I feel like if you've completed all of the documentation, you have a thorough eval, that a CODA should be able to read that eval and know what to do.
Well, no, I agree. I don't think it's saying you have to have one, but be available for one. So if there was a question,
You're right.
that's part of supervision.
And you're right. It does just say be available. It doesn't mandate that you have to have one.
That's how I read that too, Kelly, and that makes me feel more comfortable that they are available if there are questions.
Yes.
Darby, going back up to the first part of C,
Mhm.
it said in accordance with current AOTA standards of practice. And then leaves off the, as maybe, as long as we assure that it's currently current.
Right.
And yes, it is. I just flipped through the standards of practice and also we were using the standards of practice when we redid our eval section. And so, yes, the standard of practice is still for the OTA to contribute to that process, but that the OT is the one who completes and documents and synthesizes those results.
So do we need to stick the word current in there? Or is it just assumed? I mean,
What are you talking about? Client care
Like we
conference?
did that somewhere else to just with things that might change that are out of our.
for C, putting the word current in accordance with current AOTA standards of practice.
And then
With-
leave off the as may from time to time be amended.
Yes, absolutely.
Yeah, I think that's a little bit more clear if you, and then drop off that last part of that statement.
Mhm.
Do we want, under the perform an evaluation and identify goals, do we want to reference the previous section? The previous section being, I guess I'm just still stuck on the idea that earlier we said an OTA can assist, and to me, this makes it look like they can't.
I know, that's exactly what I'm thinking. I feel like it's a little confusing because it's like
Right. But if we reference the previous section, perform an evaluation as outlined in section, whatever it was, then
Yeah,
that would make a match, right?
Mhm.
Okay. I'll find this section.
So basically, I'm just trying to condense this all in my head because I feel like so much of this document is repetitive. Like, the purpose of this section is the supervision, and it's basically saying that prior to the plan, the OT has to do the evaluation, identify the goals, and ensure that the assessment's written and be available for a conference. But the assistant can assist in that entire process, except for the documentation of the assessment, right? Writing the eval. Like, do you see how it's, I just feel like it's,
Do you think it needs to go in the other section where it talks about the responsibilities and?
I don't know, I'm just trying to consolidate it. Like, I feel like everything is like, there's so much stuff, so many different places. Like, how do we make this so that like it's
Yeah, I will say that when I'm looking for this one, part about the being accessible, I always forget where it is. You would
I
think I
know.
would remember it was in supervision of OTAs, but I always want to go to the service delivery part. And then,
Right.
nope, it's down here. So I mean, would make sense if just one sentence was added in
Up
that
in the part
section.
about the evals.
The vows or the intervention process, if it was just written there. And then it would just kind of flow, because
And is it better to put this part first? Like, do we talk about the supervision first and then we talk about like what all pieces and parts that they can partake in?
We redid the eval and intervention stuff based on the AOTA because they delineate it there, like the OT can do this, the OTA can do
Right.
that. Like, so we kind of already used AOTA. What I'm hearing is that right here under 4913A, let's see.
actually
The
probably
OT is
after the
responsible
evaluation.
for the documentation and review of the intervention plan. Would we right here say, the occupational therapist is responsible for, having intervention plan completed and accessible prior to any, intervention by the occupational therapy assistant?
No, I mean, because that's the intervention process. Like, that's not like
Can you
that's
go-
after.
Can you go up to the evaluation part, the last part of the evaluation? Okay. An OT assistant may contribute. And then what if you just put a statement, the same statement that was in the supervision part, just making a K, or I mean, a K, an M, that this, completed document must be accessible to the OT prior to whatever the other part says.
Mm.
Yeah, prior to the administration of OT by an OTA, the supervising OT shall ensure that the documents are recorded and accessible to the OTA prior to the first treatment session.
Repeat what you said.
I just read,
Read it out for me.
okay. Prior to the administration of OT by an OTA, the supervising OT shall, comma, in accordance with current AOTA standards of practice.
Okay.
And then and then skip numbers 1 and 2 where it says, wait. Do we already have in here where they have to create the goals and stuff?
We, below that under intervention process, intervention plan development, we talk about the goals being created. The OT ensures that the intervention plan is sufficient to justify services. OTP collaborates with the client to develop and implement the plan.
Oh, then maybe it should go down there. Like in number 4. Maybe it should say, and where you just started typing up there an evaluation, actually in number 4, because that goes through the whole process of the writing, using the evaluation data to write the goals and plan. And then number 4 could be that before the OTA does the first treatment session, that this has to be accessible.
So would all that part make more sense to put it under the OTA stuff?
You mean all of this about the eval?
Well, no, just all the assistant stuff, kind of like when we saw like in, I guess it was, what was it, New Mexico's, like they talk about supervision and the supervision is all about like your definitions, like the complexity, the number, the diversity of clients, the practice setting, and then it's more like task delegation, or more like what parts can they do as part of supervision, right? Because they can't do this without supervision, but yet we have it like in the eval section. Like, I kind of feel like all that should just be like OT stuff. And then once we get to supervision, we say exactly what the OT assistants can do.
I don't know. I mean, if
think
we did that, we would be moving away from how the AOTA has currently got it. And to me, it is two different things. Like, the tasks that a CODA is allowed to do is different from the
But this is task.
supervision.
This is task. Like,
No, that's why I'd like to keep the task here, and this task of making sure that the document is as accessible to the OTA is a task of the OT that should be, to me, here.
Yeah, it's not telling you really that how much they have to supervise the OTA at this point.
It's not.
And I feel like that's what we had before, was there was no mention of the OTA and the intervention process or the evaluation process. Like, it wasn't even, they could hardly do anything except the implementation of the plan. They couldn't do the evaluation. They couldn't do the intervention plan. They could only do the implementation.
okay, I just feel like it doesn't make sense in my head organization wise.
Yeah, I don't know. Does make sense to me, but
Okay.
that's kind of why I felt like it actually should go in A, because it's like a task for the OT, where we say the OT has the overall responsibility for the development, documentation, implementation, modification, and review of the intervention plan. Comment including ensuring that the evaluation and plan is accessible to the OTA prior to the OTA intervention. Something like that.
Yeah, I mean, you could go back to like where it says number 3, like accessible to the assistant prior to the first treatment. Is that what you mean?
Yeah.
I mean, it's exactly what number 3 says, accessible to the OT assistant prior to his or her, we got to take out his or her, prior to the first treatment session with the client.
Right.
But it doesn't say who's his or her. Is it prior to the OT or OTA's first treatment session?
Are made part of the client's record and accessible to the OTA prior to, it does say his or her, prior to the OTA's first treatment session with the client.
I'm just writing it and then we can fix it.
Yeah.
So this is the new sentence. I'll just change the color. So, well, no, that's a horrible color. Okay.
Go blue, purple, perfect.
An OT has the overall responsibility for the development, documentation, implementation, modification, and review of the intervention plan, including ensuring the completed documentation is available to the OTA prior to OTA treatment intervention.
Are made, well, this says are made part of the client's record and accessible.
Is part of client's record and accessible
To the OTA. Prior to the OTA's first treatment session with the client.
Well, I like it, but what else? Anybody? We can come back to it too.
And then do we keep the part that's, wait, I think you need to leave it a different color just because we have to
Okay.
vote on it and it's in a previous section.
Good point, good point, good point.
So read the next statement and see. Occupational therapist is threshold setting. Yeah, okay.
Okay. So when we're here, we talked about possibly B might not be needed. We'll see.
Right.
Now we pretty much moved C, except for the idea that being available for a client care conference. We just moved all of the C1, 2, and 3 to that other section.
So in the supervision part, can you just well,
So yeah, I think now we're finally getting into the meat of supervision, I guess you'd say.
Yeah. But that's what the section's called. So I feel like that's where it should be. Like
Now we've got to talk about like what we right here, right off the bat, our current level of supervision says we have to do it periodically, which means every 2 weeks or every 6th visit, whichever comes first.
right.
So if we want to move away from that frequency to 30 days, or if we think that supervision should still be have a visit number on it, that's what we talk about during the duration of the program.
I mean, I feel like the very first beginning part of the OT assistant supervision should be like
Some definitions.
or referring to things like, yeah, if we're gonna keep definitions of like kind of how the other states did of just like post supervision, or what supervision means. Like, I know we're gonna have a definition part, but like specifically about supervising, and then whether, it's based on skill level, competency, all that stuff. And it's kind of in here, but it's kind of not, like it's,
I agree. I actually really like the way other states had definitions relevant to that section in that section.
Yeah. And I mean, maybe before we do this, we have to make some decisions about how we're going to write this. Like, how do we want it to look? Do we want it to be based on hours? Do we want it to be, like what's going to be our standards? Because it may look completely different than this. So we may waste our time like going through paragraph by paragraph if we know exactly like what we want to say. And I think we should use some of the other state stuff, and look at which one do we like, which one do we agree with, what are we thinking?
I agree with that. I mean, we could talk now, I guess, about some of the things we looked at with the other states. Like, do any of us feel like there should be supervision differences for the OTA based on years of experience, for example? Because that's all going to come up, and it's all going to become a piece of all of these different definition.
Yeah.
Ingrid, what guidance does AOTA give in regard to the specific question of numbers of?
They would prefer that there's not, they would prefer that it's all based on clinical reasoning and things like taking into consideration the complexity of the client, kind of like the way North Carolina and Texas have it written, and Massachusetts, where the OT is taking into consideration the complexity of the client, the experience of the CODA, the competency level of the CODA, and then making the decision about how close the supervision should be. They don't want there to be numbers.
I personally feel like that makes more sense when you look at the broad scope of OT and across all practice settings. It just becomes more encompassing and clearer to everybody what that expectation is.
So their words specifically were not too specific that would cause frequent change and limit the scope of practice in a variety of settings with a variety of clients.
That was going to be my statement too, is that I feel like if you get away from using numbers, then it increases the longevity of the document and keeps us from having to feel like we need to revise something in the future based on some number that we decide on today.
Yeah, so it just, and that's what makes it so hard, is because we're trying to include every practice setting. But that's why we have a diverse group on the committee to look at school setting, mental health, like acute care, things like that. So, I mean, I don't know if we want to go back to the document of the states and kind of look at things like that. We can look at North Carolina, New Mexico, whoever we want to look at as far as just the supervision section.
Sure. Let me save this and then.
I'm liking a lot of the wording in the New Mexico, and maybe just because I'm more familiar with that. But
Yeah,
I think a lot of the wording in that one.
I just think it's super clear. I think the North Carolina's is really good. I like the organization of delineation of clinical responsibilities. I think it just makes it super clear, whereas I'm not quite sure yet because I have to go back and really study all the changes we made in ours. But we can go off the shell of New Mexico or another one that y'all see.
I thought I was on the, I thought I moved the screen sharing to the screen that has, the agenda and all, but I didn't.
Oh,
Might need to turn it over to someone else. I don't know.
okay.
I don't seem to be able to find that. Let me see if it was this screen.
If not, you can let me know and I can do it.
Yeah, I can't figure out. Can do you have screen sharing capability?
I'm looking. Yeah, I just have to figure out, yeah, let's see. Did y'all see it there?
No, it's still what I had put up, which is, I think we're looking at North Carolina's Practice Act right now. Yeah, we are.
Well, yeah, but isn't that what we were doing? Not
Yeah,
the
but
practice-
that's just something that I put, that's not the thing that was on the agenda. That's not that has all the states. This is just North Carolina's that I had pulled up.
Somebody's scrolling through something I can see.
That's me. I'm
States.
trying to get to I was on New Mexico, but she said it was the wrong thing.
But you haven't shared it.
It just popped up for me.
It did? Oh,
I'm looking
It
at
says
it.
that I'm
I have two screens
sharing.
going and it's on one screen and what you were sharing is on the other.
You may have to stop. Did you stop?
oh yeah, let me stop my share. Okay.
And there you go.
Oh, now I see it. Okay, I had to stop my share. I apologize. All right, got it.
So the New Mexico one, here's the supervision, how it starts. OT assistance, supervision involves guidance and oversight. professional growth and competence, responsibility of the OT and the assistant to seek appropriate quality and frequency of supervision to ensure safety and effective OT service delivery. Frequency, method, and content of supervision may vary by practice setting and is dependent on the following. More frequent supervision would be necessary for complex and changing clients, practice setting, ensure safety. I mean, we can definitely tweak this as to what we want it to say, but it's just sort of like if we use this as a shell, if everybody likes it.
I do. This is very much like North Carolina's. The only
Yeah, look at-
difference is North Carolina does put in a minimum of every 30 days. Which there's definitely a piece of me that likes that. I will
Yeah.
say that the majority of the states that we reviewed did include a 30-day.
Yeah. Theirs just says, you know, well, that's just 3 or fewer here, assistants, like if we're gonna get into that. And then after the first year of license, you have to just make a decision on the appropriate number of assistants to be supervised.
I just want to make a comment about the number of OT assistants being supervised. I believe that some states included that when some skilled nursing facilities were sort of creating a system of 1 OT and then 10 OTAs in 8 different buildings, and the 1 OT is responsible for all of them. And that this limiting of it was a response to that, I believe.
Yeah, I mean,
And
I think we need to put some parameters on it.
I think it's a nice idea. I think it has been a thing that's been abused in our state because we have never had a number. That's a situation where I think a number might be a good idea. Because I do think that that has been abused occasionally in our state.
Yeah. So this just talks like specifically about that, but doesn't like really get at this point, like more of the definitions of like, if we're gonna do close supervision, you know, like those types of definitions, like how Alabama did direct, close, general. So do we want to start more with this, or do you want to start more with like?
Can
this
you
type
scroll, where are New Mexico's definitions above this?
They don't
Yeah,
have,
yeah, it's right there. There's the definitions.
yeah, but it's aid, board, competence, competency, limited permit holder, which looks like a temporary licensed person.
Mhm.
OT assistant, supervision, and supportive services.
So they just don't, unlike North Carolina, they don't have a definition like for general and direct supervision. They just don't have that.
Well, if you look here under this section where it says occupational therapy shall not be performed by an occupational therapy assistant, aide, or technician, or by any person practicing on a provisional permit, blah, 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 the board shall adopt rules defining supervision, which definitions may include categories like close, routine, and general.
Okay.
They mention it, but it's the board, but we would put ours in this document.
Right.
So we would just need to decide if we're going to actually be that specific and then define them. I mean, AOTA has the definitions of all those, and I hope that we don't change them, make them different, because that's really confusing.
No, not at all.
I wouldn't want to change them at all, no.
I mean, the guidelines to supervision also like kind of starts out like under their general principles, like kind of talks about very similar to this with, you know, specify a specific frequency method. They just give you examples as like direct face-to-face if they don't really. I mean, I feel like if we're gonna define close supervision or whatever the AOTA's things are, like, then we have to specify when to use them.
Right. That's what I think. If we're not
Because
gonna,
they're not doing that in some states.
right. There's no reason to even bring it up if we're not gonna implement it in a certain part.
Right.
I definitely think, for temporary or, student situations and things like that, but if we're not going to be that specific for OT and OTA.
I mean, I kind of like how the states did it changes for new practice setting and new skills.
I'm actually not a fan of that. I mean, an OTA, when they've done 16 weeks of field work, compared to the 24 for OT, and they've had a lot of schooling. And I think when they graduate and pass their NBCOT, that they shouldn't, just because they move to a different practice setting, they should suddenly be supervised more. But also, if we have it in the way that the way New Mexico has it phrased, it's all about the OT using their clinical judgment. How complicated are the patients? How much experience does the OTA have? So rather than putting like a number on it or saying, okay, now suddenly you have to have this kind of supervision, we're just saying the OT needs to take that into consideration.
I'm fine with that. I guess my question would be to those of you who work in these settings, how much pressure from your employer dictates that versus the OT, like really being comfortable and being able to like speak up, and you know what I mean? Like, I just feel like there's so much pressure from employers of like, you're going to supervise this many people. And if somebody's really not competent, are they, I don't know. I've not been in that setting. I've always kind of wondered that of,
Yeah, I haven't really been in it in a while, so.
like a new assistant. I don't know. I mean, I don't understand the whole process because I haven't been through it. Like, I understand how it's supposed to be. I just don't know how it is in reality. But this is North Carolina's that I have up, and they basically start with a definition of supervision and then talk about like the general and then the direct.
But direct is not for OTAs at all.
Right.
Direct is only for unlicensed personnel.
Yeah. So, I mean, we have about 20 minutes left, so I'm not sure, if y'all want to start maybe with more like this part of the supervision, and then under this, we would put more of the definitions, or start with the definitions.
So, right now we do have face-to-face requirements for less than 2 years. We have a close client care supervision for 25% and then 10%, which that's a little confusing. Rather than just saying direct like AOTA does, we call it close client care, which is face-to-face observation.
Yeah, but Kelly, I think we wanted to get away from all of that.
Right. No, I agree. I was just saying it is in there right now. When you were saying that doesn't apply to OTAs at all, we do have that in here right now.
Oh, no, I meant in North Carolina's.
Okay, I'm sorry. Okay.
Yeah, in North Carolina's rules, their direct supervision, they never supervise OTAs using direct.
Okay, gotcha. Sorry.
They
So
only
maybe
supervise using general.
Why don't we kind of just spit out some of the things that we know that we either want to keep or get rid of? Like, are we definitely gonna, like Ingrid saying, like the minimum would be like the every 30 days?
How many people agree with that?
Like, that would be the minimum.
Regardless of experience. Is that what you're saying?
Yes, we would be saying like, we wouldn't have any supervision guidelines based with numbers based on experience or setting, we would say that the OT needs to, like this that we're looking at, number one, A, B, and all of that, that the OT would need to determine how much supervision to provide based on that.
Mhm.
But that at a minimum, to me, I think there should still be at the minimum, an OT is providing some type of supervision to the OTA at least every 30 days. That's me.
So when
I
you,
realize that New Mexico doesn't require that, but that would be me.
okay,
And I don't work with, I don't supervise CODAs, but I kind of like the concept of like having that minimum for the 30 days.
I do too.
Just because again, it lets it be something that can't just, oh, we lost track of time and it's been 2 years now, we should
Mhm.
sit down and have some supervision.
Okay. So I'm gonna take notes and then go back and find like in what states had like that statement. Because I remember me reading it, it had to have been one that either I did or the two people who are absent that said like, no matter how much experience, like the minimum was like all OT assistants require a supervision.
Exactly. That's part of the AOTA.
Yeah.
if we have just a supervision vocabulary and use general supervision, it says it means at least monthly direct contact. So
Is that AOTA's definition, Kelly?
general supervision means at least monthly direct contact with interim supervision available as needed by other methods.
Well, whose definition are you reading?
AOTA.
AOTA's, beautiful. That must be where North Carolina got it then.
And it says as needed by other methods, and applies only to OTs with increased skill development and mastery of basic role functions, or OTAs as appropriate for the delivery of OT services. Minimal supervision means supervision provided on a less than monthly basis to OT assistants when performing non-clinical administrative responsibilities. Routine is every 2 weeks. Close is daily direct contact. Continuous applies to aides. So those are all AOTA's definitions.
Okay.
Is that in a document that you could send me?
I have
So
a whole
I know.
PowerPoint on it. I can send you. I might have to change it all now that we're changing our rules. It took me forever to do this.
But no, but it just would help me like give me like a basis, like, you know, of how, because I guess what I'm envisioning is like me or Ingrid, somebody like
Yeah.
coming up with a draft,
I think so. I think that's going to be the
going
best.
through it and like having all the things that we know that we want. Like, do we want them to co-sign? Do we want them, who do we want to like keep? Do we want them to, you know, like one of the things is like maintain the supervision log for 3 years. Like, do we want that in there? Like, what are the things that we absolutely feel like have to be in here?
Right. I agree. I think it would be probably easiest if we come with a draft and then pick it apart.
Yeah.
So Kelly, you got this AOTA definitions. You know what those are? Those definitions in the practice framework?
No.
So they're in, hold on.
Do we want to mention aides, text?
I think we ought to. We do not currently have anything about supervising unlicensed personnel, and I kind of think we should add that.
Everyone agree?
Mhm.
Okay. Do we want to require that the OTA maintain the supervision log? Who does that now?
Do what?
That someone maintains the supervision log for 3 years?
Oh, like the first 3 years?
We don't currently require a supervision log, do we?
No.
No.
Okay.
Used
I don't
to.
think. I don't think we
thought
ought to
did
go
it one
there.
time. Okay. What about documents being co-signed?
Documenting what?
Being, all the documentation being co-signed, we want that, correct?
Oh, well, I don't know. No, you don't want to have every progress note have to be co-signed.
Mm-mm.
Okay,
I
Now,
think
they could refer to the supervising OT like Texas does.
I think that's really interesting. I like that idea.
That puts
Yeah.
accountability, but
so
without,
where they name the person, where they name the supervisor, okay,
and it doesn't have to be the person who does the plan of care. But, you know, so if that person's gone out on maternity leave or whatever, that was, we have.
It's the OT that was available to them during that
Right.
session.
that's
They,
treatment,
no,
okay.
they have to make sure that somebody else is available.
And be
Right.
able to name them. I did
Yes.
like that. And what about limiting? Are we gonna say no more than 3 assistants at a time?
That one may require more thought.
It is. It'll require more thought.
Okay,
A lot of scenarios I can think of.
There are a lot of scenarios. I don't want to make it, that's kind of how I feel, but I think it requires more thought and finding out from more people who are actually practicing with OTAs.
all right, I'm gonna just put a question mark by it because it's something that we definitely don't want to like have it fall off the radar, but
Right.
okay. I'm gonna go through all the notes from each state and look at it. Is there anything else that I'm missing? So what about new to a practice setting? So if somebody's been working like in one, like home health, whatever, and they switch to peds, leave it up to OT, correct?
Yeah,
Yep, okay. Do we want to make any provisions different for school-based?
that might require more thought too.
Okay,
I don't think it needs to be as strict as it is now.
Yeah.
right,
Let,
Okay.
let me ask you about the competency log, which Darby might have been what you were confusing it with. Currently, we have competency logs for OTAs. And that is kept by, I'm pretty sure that's kept by the OTA.
The competency law, it has to be kept at wherever they're working. I mean, they can.
That's what
keep
it
but
is. That's
has-
what it
yeah.
was. That's what we said. It has to be kept wherever they're working.
okay. Are we gonna still
Some
require
states
these?
don't require a competency log. We saw that many don't.
Right.
I don't know. We might have to chew on that one a little more too.
Okay, that'll be another question mark, but we need all that in here, so. Yeah, I think I think Arkansas called it a supervision log. No, I'm confusing it. You're right. There's the difference between competency and then the supervision. Okay, and then we're gonna use the AOTA definitions.
I can find them.
Like direct, closed, general, something like that, right?
Mhm.
Okay. And are we gonna talk about anything about like putting basically like face-to-face, video conferencing, telephone?
I think if we're gonna start to say that they have to, you know, have general supervision, what that would mean. Does it mean on premise? Does it mean teleconference?
Mhm.
I mean,
Yeah, I would like to see the definition of general supervision include video conferencing and phone.
So this one, the New Mexico one states, it said, it's written like examples of methods or types of supervision that involve direct face-to-face contact include but are not limited to observation, modeling, co-treatment, discussion, teaching, instruction, and video teleconferencing.
And that's exactly the way North Carolina's is written too. That's like
Yeah.
verbatim.
Example of types of supervision involved indirect would be are not limited to phone conversations, written, electronic exchanges, or other methods. And then just saying that they have to be compliant with confidentiality requirements, which I really like. And I think that's how it's written in the guidelines for supervision. that we have. Yeah, it's word for word. It's exactly word for word from the guidelines for supervision roles and responsibilities. So, okay. Okay. So, do we have any public comment, Dr. Van? Dr. Van? You're on mute.
You have no public comments at this time.
Okay, thank you. So we're just at this point going to agree to draft
Yeah.
draft, like basically come up with a draft for the supervision, which will be presented at the next meeting, correct?
Yes.
And we can go from there. All right, and then we have the next meeting as May 12th. And then we have a change in the August meeting to August 18th. So everybody can make sure you mark your calendars. It was the 11th, will now be the 18th. Okay. So any other questions or comments or anything?
I don't think we have to take a vote on anything because we didn't really decide anything, so.
Yeah, agree. Okay. Well, thank you all. I know this is like super laborious, but we're gonna get there. Hopefully it's the hardest part.
Yes.
All right, thank you. And Ingrid, let's just get together about the next phase.
Okay.
All right.
So are you closing the meeting at 12:54?
Yep, we're gonna adjourn at 12:54.
And thank you all
Happy
for
Oak-
all your hard work. I really appreciate it.
Thank you, Dr. Van, for
Thank
all your
you.
help.
And Dr. Van, we'll get together about the email.
Very good. Yes, ma'am. I'll start a draft and I'll try and get it to you Monday or Tuesday.
Sounds great. All right, and then we'll see y'all next
May
May.
12th.
See you May 12th. Thanks, guys.
Bye, y'all.
All right, thanks.
Bye.
Bye.